Hey everyone, welcome to the UK Hangout. We have a really special guest today. We have Dr. Hannah Mathew. She is an internal medicine doctor who specializes in metabolic and lifestyle medicine, which is hard to find, few and far between in the United Kingdom. And she might have a few different types of philosophies than some of the other doctors out there. Always remember it's important to understand the standard protocols for your presentation of any disease, and always know that we defer back to your healthcare team for what is right for you. But that being said, some great food for thought ahead. We have a wonderful guest, as I said. Welcome, Dr. Mathew. Thank you so much for being here. I want to start with just a little bit about yourself. You're from India, but you are now in the UK practicing medicine.
Yes. So I studied medicine in India and then I moved over here to the UK because my husband is here. And I was always a physically active athlete and all of that stuff. And I was going under the conventional medicine path for a long time. I was training, I was going to become a super specialist, very ambitious, until I kind of got diagnosed with endometriosis and autoimmune thyroid disease. And it was a very devastating diagnosis at such a young age. And then that's how I kind of got into lifestyle medicine, functional medicine, started to do a lot of research on metabolic syndrome, health, and just started asking more questions instead of just blindly, being a good student and just studying for exams. And that's how I've kind of ended up here.
And so, those who are thinking differently, like you, few and far between in the UK, have you faced any resistance to your philosophies and your efforts there?
When I discuss a lot of my research with doctors, especially older men, they're just putting up a wall. Like they're not ready to kind of argue or even look at alternative evidence. I have had some junior doctors who are kind of engaging with some of the things that I say, but few and far in between, unfortunately.
And so, you have a full practice. Who do you typically see in the UK for your patients? Are you, you know, really the frontline gatekeeper, primary care, or is there a step, between you and general internal medicine?
So I'm practicing general internal medicine. I have 6 months experience in stroke medicine as well. So very familiar with metabolic syndrome and health and all of that stuff. But at the moment, I'm practicing internal medicine, geriatrics, particularly. Most of my patients are old. And then I also do quite a lot of shifts in A&E, so emergency medicine. So I'm seeing kind of a mix of old people and then acute cases such as heart attacks, strokes, things like this, dementia, infections, a mix of everything, which is how I like to keep it because I think it helps me have a variety of cases and understand things from different perspective and not get into tunnel vision, which tends to happen when you're a super specialist. You see, each organ as separate and you go to different specialists. That's not the kind of medicine that I believe in. I don't think it makes much sense from a physiological point of view.
How do you balance the standard protocols and metabolic medicine and the natural philosophies as you are treating these patients, particularly who do have vascular and cardiovascular issues, including stroke?
It's really difficult. But what I have found that um, the way I practice medicine is very patient-centered and very much from compassion. So when I'm going to see a patient, even though it's in the hospital setting, I am seeing them as a human first, and I'm talking to them and finding out more about their lifestyle. What's their diet like? What is their stress level like? Why are they smoking? Not just, oh, stop smoking, it's bad for you. Are they often what I find with my a lot of patients who are, smoking a lot, drinking a lot, they're doing that in order to numb something a bit deeper. So that's how I practice medicine. It's very different, especially now that people are going into AI and stuff like that. I'm not like that. I'm very old school. For me, medicine is all about human connection first. I don't see the body as a machine. So with each patient, the reason why they have a heart attack might be slightly different. Obviously, underlying insulin resistance and inflammation is a key factor, but why that's happening is probably different for different people, if that makes
I
sense.
love that you look at each person as an individual and really get to the heart of what's driving that inflammation, because we have so many patients that come to us with P.A.D. and they say, I don't really understand why I have peripheral artery disease, or I don't understand why I have had a heart attack. And they'll say, I have normal cholesterol in a basic lipid panel, and yet no one has offered them an advanced lipid panel to determine the quality of those LDL, the bad cholesterol. Do they have a bunch of large, fluffy LDL cholesterol particles, or they have the small, dense LDL particles that, when they become oxygenated by the free radicals and other things, trans fats and such, that they can eke into damaged areas of the artery walls, right? And you got to get to, well, then what's damaging your artery walls? That's really at the heart of it, is it not?
Exactly.
And
Exactly.
so, go ahead.
So I think the way that we are practicing medicine now, if you go to a cardiologist or a vascular surgeon or a stroke specialist, they're super specialists, they're very protocolized. So the protocol is, okay, someone's coming in. What I need to do is look at their HbA1c and then give them some drugs to put their sugar down. Okay. If their blood pressure is high, I need to give them some drugs to reduce their blood pressure. If their cholesterol is low, I'll still give them 80 milligram of statin. I don't care. That's protocol. That's kind of how medicine is practiced now. And after that, your doctor will see you. They'll look at your cholesterol level. Excellent. It's almost zero, but the patient is still having symptoms. But then the doctor is like, look, I've done my maximum. I've given you all the drugs that are in my toolbox. Patient is still having symptoms and goes home. And it's quite pathetic, I think, for the way that it's being practiced. I mean, clearly we don't know something is going wrong and we're not able to explain it. Instead, we're just saying, okay, bye bye, here are these drugs, go home, even though your symptoms are still there. So it's just most of my patients that I see in the NHS are just constantly coming back, more and more
Yep.
symptoms,
Because
more
we're
and
not
more
getting to the heart
we're not getting to the
of
root
it.
cause, as you said, which is, that LDL oxidation. We are obsessed with lowering LDL cholesterol. Okay. We don't really, without really understanding what that is, what does it mean? What is the implication of it? What even is cholesterol? Most of my patients, they're so scared of cholesterol, they don't even know what it is.
Yeah. Yeah. And that's really true. So hopefully during this session, we're going to get to the heart of it, but we also need some actionable items for patients. Not everyone has access in the UK, whether it's Wales or even in Scotland, to someone like you. So it's going to be interesting how we can help them to have a more productive conversation with their doctor and make the most informed decisions for their health. I mean, this is obviously, we're not anti-statin at all. This is not what this conversation is about, but it's helping you as the patient to understand something that's even more important, that's going to help you become a better partner in your care, which is this metabolic syndrome. This is the root of what's really going on. And there's so much you can do as a patient outside of medications to really help improve your prognosis. And so with that, Dr. Mathew, do you mind if I bring up your presentation?
Yes, of course.
Here you go. And then just let me
Yes.
know when to progress.
Yeah, I am. Yeah, so hi everyone. My name's Hannah. I am an internal medicine physician and also an independent researcher in the field of metabolic syndrome, lipoproteins. The past few years, I've been doing just too much research on LDL itself, LP little a, all of that stuff. In that process, I've also become a bit of a anti-pharma critic. So that's definitely my bias, I will admit. But I'm gonna go over it in a neutral way and just explore the evidence using critical thinking. And I want my patients and I want people to ask me questions. I want them to ask their doctors questions. And I really think my whole philosophy is to empower patients. That's it. Empower them with the information. that they don't really have access to, because the way that the NHS works is you go to a doctor, they give you medications, but then you don't know what that is, what is it doing to your body, and how much it's actually benefiting you. And then often if you're developing side effects, your doctor might not really take you seriously. That's what I've noticed in a lot of my patients, at least. So my goal is to empower them and make you live a healthy life. You can go to the next slide. Full disclaimer as well, I'm not paid by anybody. So all of my research is unpaid. Haven't been paid for the last 7 years since I did a paper on metabolic syndrome when I was in India. And during this time, I actually noticed I collected data on about 200, 300 patients and noticed that most of the people who had heart attacks did not have high LDL cholesterol. They had metabolic syndrome. So I did find this during my research, which I had done over the course of 2, 3 years. I was in clinic literally measuring people's waist. I was doing the blood test myself. And at that time, I noticed this, but then I didn't do anything about it. I was just really stressed and busy and just went on with my life. And maybe I didn't have the capacity to question something that was, so ingrained into my medical curriculum. But ever since then, after recovering from my own chronic disease, I have been researching this with a very open mind and critical thinking, and then also relating that to my real life patient experience. Pretty much, every day I'm seeing patients, lots and lots of patients of different ethnicities and different age groups. A lot of them are on statins. A lot of them tell me, how they feel on it, their side effects. So I'm very patient oriented. And if someone is telling me that, someone has told me, doctor, I couldn't walk for many years because I was on a statin. And when I hear that even one person telling me something like that, I'm not happy. So next, if you go, yeah, you can go next. Yeah, I want to say like the pharmaceutical industry, the way that they conduct research, we have to be skeptical about it. We need to look at the actual data from the research that they produce and whether that data is being analyzed by independent scientists such as myself. And I will give you some examples for that as well going forward. If you go forward. Yeah, you can next. So I just want to ask, do people know what cholesterol actually is?
Whoops.
You can go back. Yeah. Yeah, you can stay there. Like if we can make this interactive, do people know what cholesterol is? Does anyone want to kind of?
Yeah, Linda, what do you think? Do you know what cholesterol is? Maybe you can answer.
I'm not quite sure actually, but I
Yeah.
think it's a fatty substance that clings to the insides of the arteries.
Yeah. And Mike?
No, sorry, I was just wondering because you were going a little bit too quick through the slides. I didn't get to read the previous one. I was just like zooming in. I don't know whether should take a screenshot of them as you're going through them, or is there a way that I can get a copy of these?
Yeah, so what we can do is we can share the slides and I can send all my resources to you guys afterwards as well. So maybe we can just make this a bit of an informal discussion situation. Yeah.
Thank you. Thank you.
And what is cholesterol?
So what is cholesterol, Mike? Yes, exactly. That was Jordy in the background. Thank you, Jordy.
That was Geordie in the background there. Sorry about that. Yeah, I'm the same as Linda. I think it's a fatty substance that your body builds up over time. I know that your liver produces cholesterol and that your brain needs cholesterol and all your other organs need it. Yeah, that's as far as I really know about it, to be honest. I know that it sticks to your arteries and that's why I'm in this situation. So.
Okay. Anyone else wants to give it a go?
I think we should call on Heinz. I think Heinz should weigh in on this one. But he might. There he
Well,
is.
I realize that everybody, you need cholesterol. I've kind of been said already that it sticks to your arteries in some form or fashion.
Okay. So, people, okay, cholesterol is a fatty substance, that is true. But it is not a fat. So cholesterol is basically a substance that ends with "ol", so it's actually an alcohol. And then fat is essentially an acid. We say fatty acid. So these are two different things. Now, if you go next, don't know if there's a picture of the cell membrane, but it's not there in this slide. But I've made a whole YouTube video explaining what cholesterol is, and I can send the link
Ooh.
later. But essentially, every cell in your body, every single cell in your body is made of a cell membrane. And that membrane is made of, something called a phospholipid bilayer, and that has cholesterol in it. So every cell in your body is made from cholesterol. So this idea that cholesterol is something sticking to your arteries and that's why you're getting heart attack is actually wrong. Because that's not really what is happening. If every single cell in your body is made from cholesterol, then what, like, how does that make sense? It stops making sense. And your liver is producing 2 grams or like a lot of cholesterol every single day, because it's not just someone said brain needs cholesterol. It's not that the brain needs it, it's literally made of it. And every single cell in your body, all your hormones are made from cholesterol. Not only that, you need cholesterol and its products for every cell in the body to produce ATP, to produce energy. I don't know if you know what CoQ10 is. Maybe Kym might
Yes.
be aware of that.
Yeah, the thing with CoQ10. So I never knew that was a measurable thing. All I saw was, the commercials that if you're on a statin to take CoQ10. And I discovered that there was a test that you can get, a blood test here in the United States. Not sure if you can get it there in the UK or other countries, but um, even my parents had depleted CoQ10 levels with cardiovascular issues. And so their functional medicine practitioners told them to get CoQ10 and gave them the amount and did additional blood work to see if it was making a difference for them.
And after giving the supplement, did that make a difference?
It actually made a difference for my mom. Yeah.
Yeah, fair. So yeah, that varies from person to person. But essentially, cholesterol is something that is so important for every cell in your body. You need it for every cell in your body to make energy. And remember which parts of your body need a lot of energy. Your muscles, your heart, your brain. So that's where you have a lot of mitochondria which produce energy, which need this CoQ10. Vitamin D, I don't know if people know, vitamin D is made from cholesterol.
Oh, really?
Yeah, vitamin D is made from cholesterol. All your hormones, estrogen, testosterone. If testosterone is an important one, right? Estrogen, progesterone, all of these hormones are made from cholesterol. So that's how important cholesterol is for your existence. And I actually think that there's a lot more functions for cholesterol in animals, in humans. But because we are just obsessed with reducing cholesterol, there's not been much emphasis on it. People haven't studied that enough, especially for brain function, preventing dementia, and things like this. They have found that nerve cells communicate with each other through cholesterol molecules, something called lipid rafts. So if you are taking a fat soluble statin that's going into your brain, you're inhibiting your cholesterol levels in your brain. Your nerve cells are not going to be able to communicate with each other. So that's why I have seen lots of studies where I saw one study where they stopped a statin and people's dementia symptoms got reversed. And I actually see in my practice, a lot of my patients have something called peripheral neuropathy on a statin. They're having tingling and numbness down below. And I've stopped the statin and they immediately get better. Same with muscle cramps. Almost, I would say, not everybody, but most of my patients on a statin have muscle cramps. And I'm not happy because I'm seeing a lot of old patients come in with falls, fractures. right? So that's how important cholesterol is. And now we need to understand, what is LDL, HDL, all of these things. I don't know if that's something we want to explore today, or do we want to focus on the research on statins and what that actually shows? What are the benefits?
It would go,
Both.
be great to go through. Go ahead, Linda.
Sorry, I said I'd just like to know both. I'd
Oh.
like to know about the LDL and the HDL and the research.
Okay.
Am
Yeah,
I
so
asking too
This
much?
is really interesting. And I'm wondering, you mentioned the D is actually made from the
Vitamin
cholesterol.
D.
Is that in conjunction with getting sunlight?
Yeah. So listen to this, the moment the sun hits our skin, there's LDL particles that will go there. They will supply cholesterol molecules to skin cells. And then that cholesterol will get converted into vitamin D, active vitamin D, vitamin D3.
I believe it.
Now, if
Oh,
you
that's
have stress, suppose I'm stressed, we need the stress hormone in order to deal with stresses in our life, right? So if we have a stressful situation, LDL goes to the adrenal gland, which produces the stress hormone and supplies cholesterol there so that that cholesterol gets turned into stress hormone cortisol. And then that cortisol hormone has a lot of functions. We need that hormone in case we have a stressful situation. We shouldn't be stressed out all the time. Obviously, that's not good, but you get what I'm saying.
Yeah, no, definitely. And you were mentioning the CoQ10, and I interrupted you with the story of my parents, but you had something more, I think, to say on
Yes.
CoQ10 and describing what it is for people.
So CoQ10. So if you look at, so I've explained one aspect of cholesterol, which is that it's part of your hormones, it's part of your every cell, vitamin D. Now, another thing that comes from cholesterol is CoQ10, which is an antioxidant. Okay. So it's an antioxidant that is present within LDL. And it's also an antioxidant that is present within our mitochondria, which produces ATP for energy. That's why a lot of patients who take a statin, because of low CoQ10 levels, they will be feeling really tired. They will be feeling low energy, fatigue. I have had a patient the other day in A&E tell me she has fibromyalgia, and she started a statin and her symptoms have gotten worse. So this is a very common side effect.
Wow.
So this is how important cholesterol is and CoQ10 is. So, and then if you actually look into the LDL cholesterol, so LDL cholesterol is not even an accurate blood test. You were talking about advanced lipid panel, that's a better blood test.
But they
Right.
don't do that, I heard, in the UK.
They don't do that in the UK.
In regular practice. I heard in some private practices they may.
Yeah. In private practice, they do advanced lipid profile. In GP practices, what I'm seeing is they just do an LDL cholesterol, and then the doctor's like, okay, take a statin, otherwise you're going to die, and bye-bye. And that's it. That's kind of how the situation is, unfortunately, in the NHS. And there's a lot of nuances we need to look into about the testing of LDL cholesterol itself. The number one thing is it's not an accurate blood test. It's an estimation. So if somebody has high triglycerides, probably their LDL cholesterol number is not going to be accurately measured on that blood test. And then part of that LDL cholesterol is also Lp(a), which is not even accounted for in that simple blood test. So it's just not really a reliable blood test at all.
And so with your patients, what do you offer that provides a better glimpse into what's truly going on?
So I have done a lot of research on this because I primarily work in the NHS at the moment. I'm limited by resources. So I do just a regular blood test, and I always check the HDL and triglyceride levels. I check their blood sugars, the HbA1c, their CRP level, which is the inflammation levels. But if I'm seeing private patients, then I get them an advanced lipid panel. That's the best one, in my opinion, because that tells me, what's going on in the body. And all of this, all of these things that are happening with the lipoproteins, the LDL getting damaged, oxidized. You need to look at the context. You need to treat the human, not the number. Because some patients, I have seen patients with extremely high cholesterol of like 8. They have familial hypercholesterolemia, and they have had multiple angiograms, and it's all come out clean. I have seen patients with total cholesterol of 1.01, and they come in 2-3 times with strokes. So, clearly there's something here other than just LDL cholesterol. You need to look at the background. You need to look diabetes, smoking, high blood pressure, stress levels. What is their diet like? What is their physical activity like? All of these factors need to be taken into consideration.
And that's a good place to come back to your presentation, the metabolic syndrome that underlies all diseases of civilization. It's a disease, and I love that the way you phrase it, it's a disease of insulin resistance. Can you explain that?
Yes. So all chronic diseases, especially heart disease, strokes, diabetes, hypertension, are caused by Western lifestyle, civilized lifestyle. And what happens? You gain obesity, abdominal obesity. Okay. Elevated triglycerides, low HDL, elevated blood pressure, fasting glucose. Now, these are the 5 criteria that the institutions have produced. Like a lot of institutions, cardiovascular societies have this as a criteria. As you can see, LDL is not even part of this criteria. And this is produced by the institutions, which I don't have much respect for, but they themselves know that LDL is not the main factor here.
Mm.
And all of this is caused by high insulin, decades of high insulin, because of your lifestyle that drives these diseases. And what we are doing now is we're treating each of these symptoms separately, right? So we'll go to an endocrinologist and we'll be put on diabetic medication. We'll be put on a blood pressure medication by the GP. We'll be put on a statin. And then if we're obese, they'll push Ozempic because the NHS surgeries are being paid to do that. So it's just treating each different symptom instead of treating the underlying factor, which is high insulin resistance. And as you can see here on the left side of this diagram, there's quite a lot of factors that are causing insulin resistance. Obviously, number one is the diet. If you're eating processed food, especially refined carbohydrates, sugars, drinking. A lot of people, my patients in the UK, they don't drink water, they drink Ribena and squash and this kind of stuff. It's just it's going to cause metabolic disaster. And then physical inactivity, sedentary lifestyle, not having enough muscle mass. Stress is a very, very big factor because stress is not in your head, it's very real. Each time you get stressed, your blood sugar is going up, your blood pressure is going up, it's causing a little bit of inflammation, and that keeps building up in your body, so it's causing metabolic disaster. And then elevated omega-6 to omega-3. I think this is really important. I don't know if Kym, you've discussed this with your clients.
Yeah.
Yeah.
So yeah, but talk a little bit about that, because there's a difference in based on the meat that you can get, for example, with red meat, grass-fed, grass-finished versus the ones that are fed grains, and then even the wild salmon versus the farm-raised salmon. We have our diabetes reversal expert that talks about how that if you don't eat the right meat, you don't eat the right fish, that'll throw off that balance and
Exactly.
cause extraordinary inflammation in your body.
Yeah. So I think I'm going to emphasize a little bit on the dietary fat and omega-3, omega-6 aspect of things, because it's really, really important. So the kind of fat that we eat makes us who we are. So when we eat fat, that fat actually goes directly into our cells to be used as energy or to be stored. Okay. Now, if you are eating people are told to eat trans fats, they're told to eat margarines, they're told to eat vegetable oils, refined oils. That stuff is industrial waste product. It has not been consumed by any humans until very, very recently. I think it was the 70s. So
Mhm.
these refined oils, they are consisting of polyunsaturated fatty acids, right? Now, a lot of conventional doctors say, okay, you should be eating these vegetable oils because they reduce your cholesterol levels. Now, nobody has actually looked into why it reduces their cholesterol levels. So I did some research and I found out that actually the reason it reduces your cholesterol level is because it causes oxidation of your cholesterol.
No.
And that oxidized cholesterol is not picked up on the blood test. So that is
Right.
how
It's picked up on the advanced profile.
it'll be picked up on the advanced profile, but then generally it will look like, oh, okay, LDL cholesterol is lowered, but that's not really a good thing in that context. Okay, and it also increases your oxidized LDL because the kind of fat you eat exactly designs what goes into your LDL and how much of that LDL is getting oxidized and going. And when an LDL is getting oxidized, it gets picked up by a white blood cell. Our body is really intelligent. Okay, we have evolved for millions of years and we have ended up here for a reason because we are able to survive. Our body is strong. So we have so many mechanisms in our body to prevent heart disease, to prevent chronic inflammation. The problem is that our modern lifestyle is way out of balance and not designed how Mother Nature intended. So with omega-6 seed oils, these even nuts in excess is not something I recommend because it can disrupt your omega-6 to 3 ratio.
Oh, really?
Yes. So you need to, you can do a test, omega-3 to 6 ratio. You can do a test to see how your levels look. So
In a private practice or in
the
public?
NHS, unfortunately, no, I'm sorry. So people would have to try it in a private clinic. It's not, I think it's not too expensive. I had a client do it recently. It was like 100 pounds, maybe 70 or something. But
Okay.
if there's one test I would recommend people do, it's omega-3 to 6 ratio, because that tells you, that will determine how much inflammation goes on in your body. So the number one thing is obviously with fats, you need to cut down all processed fats, all the trans fats, all the vegetable oils. And when you do that, automatically you're cutting out all the supermarket processed food that you get. You know, most people in the UK, they're living on sandwiches and ready-made meals. That's a big no.
Mike, you
need
got to
to-
tell your mom.
And you really need to.
He's
You know,
laughing.
I was just thinking that actually.
I
My
know
mum
you
lives.
were.
Yeah,
Saw your
she
face.
absolutely lives on microwave meals every day, and you know she's got P.A.D as well. She's a bologna amputee. She doesn't. Well, she does take it seriously, but you know there is some things that she bypasses, and that's one of them. Is her daily meals. She's probably listening to this now on YouTube because she watches them on YouTube, so she's probably going to kick my head in later.
Hi, Mom. It's my
Yeah.
fault. I called her out. It's my fault, Mom. But also I just found out, Dr. Mathew, that Lint, I think it's called Lind chocolates, the filling is all this vegetable oil. It's not really chocolate. The
Yep.
actual inside that's oozing is actually highly made of the vegetable oils,
Yep.
which
Pretty
is really
much
disconcerting.
most processed food, like, that people eat day to day is contains vegetable oils. It contains a high amount of sugar. It contains emulsifiers, lecithins, all of these things that are just not only causing inflammation in the body, they're compromising your gut health. And gut health is also another important factor I'm going to talk about.
And Marie,
So,
before we move on, Marie has a question. At one point, she was on 3 statins because of how much her platelets stick. we had a nurse practitioner who's a friend of both of ours, nurse practitioner Kay, who got that changed to just one. And with her clotting disorder, she's asking, is it better that she's on one statin versus 3?
What statin is she on?
Marie, you're going to have to jump in really quick if you can.
Right now, I'm on that Riviostatin with
Rosuva.
calcium,
Okay.
40
How many
milligram.
40 milligrams. So yeah, so I think out of all the statins, rosuvastatin is the safest one in terms of side effects. So because it's a water soluble statin, that is the safest one that you know, I would recommend if someone's really still terrified to get off a statin. Rosuvastatin is the safest one, and also it
Should I
really
be on
depends.
a higher dose or on multiple? Because my clotting disorder is not like any other, like you've seen. It's bad.
Okay,
Is
and
just the one at 40 milligrams sufficient, do you think?
so if you're on a clotting disorder, I'm wondering, are you on aspirin? Are you on antiplatelets? Because that's more
Yep,
important.
I'm on all of that, yes.
Yeah,
I'm
so
on Plavix, aspirin, Eliquis. I'm
okay.
on the statin. I'm on Azenbite or something. It starts easy something.
Okay. Yeah, so then the question is, are you able to tolerate the statin? If you are not getting too many side effects, because a lot of patients, they are suffering from the side effects and they're not aware that it's a side effect. They just think it's a normal part of aging or like it's normal. So
I've been
that's
lucky where I haven't had any side effects with any of my medications, knock on wood.
okay. So that's good. In that case, if you're okay to continue it, I'm okay with that. But then we will look at the research on statins in my presentation soon as well. So
Okay.
after that, I can't provide medical advice, on this. So it's really your discretion after looking at the research whether you.
Okay.
Yeah,
Yeah.
but here in the United States as well, I mean, you have more access to the advanced lipid panels and such that you can do here, and they are covered by insurance as well. CoQ10 is covered by insurance. The omega-3 and 6, I'm gonna have to look that up
Yeah.
as to whether it's
But
covered, but
Should I
even if
add
you
an
don't,
omega to mine?
so omega, if you eat fish, I would just say eat fish, eat sardines or cod liver as a whole. With omega-3 supplements, there are some issues about quality.
yep, it could be
Um,
rancid.
it can be rancid, which will cause more problems again. So I recommend eating 4 to 5 servings of fatty fish in the form of sardines, mackerel, wild salmon in a week. That's what I personally do. I don't take supplements, and I think
All
we
right,
should
you
really
didn't
focus
say
on whole
cod.
foods.
Is cod not one of the good ones to eat?
Cod liver, yeah, cod liver. Cod liver is really good.
Okay.
Very, very high in vitamins A, D, E, K, as well as omega-3. So you get it in
Okay,
a.
yeah, because that's my favorite. That's the one I use the most.
So
Okay,
if you
thank you
like
so much.
cod liver, you can literally eat that as a snack. Like I love it. I'm from a coastal area, so I love fishy things. So um, definitely eat real seafood, eat real fish. Otherwise, krill oil is something you can think about as well. I think that's less rancid than the generic cod liver oil that you get.
Yep. Okay, so we have about 12 minutes left in this particular session. So but you're more than welcome to come back again next week. And we could finish up here and then we can have additional conversations again next week. But just keeping that in mind as we
Okay. In which case, I can just quickly go over my like what I've seen in the statin studies, just so
okay.
that people are aware. If you go next, so yeah, yeah, so I have so many questions about statins, cholesterol, LDL, LP little a. I think if I talk about this, it'll take me hours. So we can go to the next slide. So as I said, high insulin, if you can ask your GP to do a fasting insulin for you, that would be really useful. It's available in the NHS, but the doctors are not taught to do it because it would kind of raise a few questions and concerns about how we are treating diabetes, which is often wrong. Some of the medications we give for diabetes are not the correct ones. So I don't think it's going to be a thing in mainstream medicine, but a lot of functional medicine doctors and lifestyle medicine doctors always check fasting insulin. So that's one takeaway. Go to your GP, ask for a fasting insulin level, and then we can go from there. Most people with PAD, I'm pretty sure they will have some form of metabolic syndrome, or they are heavy smokers, which is why their blood vessels are getting damaged. Okay, so next one. Yeah, so this is an interesting one. Sumo wrestler versus this skinny guy. Who thinks that the skinny guy is healthier?
I mean, you
I
would
love
think.
sumo. You would think, but the reality is different. Sumo wrestlers have all their fat stored under their skin, not in their organs. So if you go to the next slide, yeah, they're elite athletes. They work out so much that they have very low visceral fat. Okay, so if you look at this is an MRI scan of two individuals with the same BMI, same body fat percentage, age, but you can see that one person has much more muscle and has subcutaneous fat, which means the fat is kind of like the good fat under your skin, a little bit in your stomach is okay. And the second picture, you can see this person has a lot more visceral fat. So even though they have the same BMI, body fat percentage, one of them, the one with the fat in his or her organs, is going to get heart attacks, strokes, diabetes, and all of these things. So that's something we need to think about as well. Building muscle, very, very important. That often determines where that food you eat is going. Is it going to go into your muscles and into your subcutaneous fat, or is it going to go store in your pancreas, your heart? Next. Yeah, so I had talked about cholesterol a little bit in the beginning. I have made a whole YouTube video explaining the detailed physiology of cholesterol, so I can send that over to Kym afterwards. I think that would be a useful slide, useful for people. I made it particularly for my patients because, I'm in A&E, sometimes I don't have time to explain. So next. So this is interesting as well. As you can see, this is actually data from 181 countries. It's showing that those who have higher cholesterol have a lower risk of death. Next. And this is data from the UK. This is published in the British Medical Journal. This is your risk of dying from cardiovascular disease. With every 1 millimole increase in total cholesterol, how much does your risk of dying from heart attack increase? Can anyone see? 0. 0. Whereas if you have diabetes, if you're lonely, if you have high blood pressure, if you have high HbA1c, if you have abdominal obesity, all of these factors increase your risk of getting heart attack. So I really think we need to focus on these other factors, these real factors, rather than obsessing over LDL cholesterol. Next. Now, a little bit about statins. A lot of the research on statins is done by a group of scientists from Oxford called CTT. They are paid a lot of money by the pharmaceutical industry, and they do not release any of this data to the public. So no one has actually had access to it to independently research the drug. And I find that really questionable and unethical. Next. This is all published research that I'm just kind of sharing. Now, I'm going to explain why is independent research important, because when pharmaceutical companies publish research papers, they often miss important findings in their experiment. They see what they want to see. If I really believe in a drug, just like when I was doing my research, if I really believe in something, then I might want to not see the negative findings in my own experiment. That's kind of what is happening. And when this drug, PCSK9 inhibitors, which reduce your cholesterol to almost zero, when this study was looked at by independent scientists, they found 20% increased risk of heart attacks, heart disease. So, but the initial paper didn't even mention that. It just said it reduced the risk of primary endpoint. And this is all written in statistical jargon that most people don't even understand. Next. Another thing with statin trials, as you can see, there's about 37 trials on statins. I've kind of gone through all of the research. After 2004, all of the studies on statins kind of show very little benefit. Some of them show increased risk of heart attacks and heart failure. Before 2004, all the studies were great. Now, what happened in 2004 was that there were new rules on how pharmaceutical companies conducted trials because there was a Vioxx scandal and a lot of patients had died. So it looks like once you remove this data manipulation and the unethical practices that the pharmaceutical industry practices, none of the trials have, showed any good benefits. If you can see that in the first picture versus the second picture. In the second picture, there's very little benefits. Most of the trials are just kind of a straight line. They're not reducing the risk of heart attacks. Go next. And now I'm going over literally every single study on statins, which has been analyzed by many scientists. You need to look at the actual data to see by how much is your risk of dying of a heart attack reducing when you take a statin, right? Most of the studies are just not, the numbers are so small. They're like 0.1, 0.5. Some of the trials are showing increased death in the treatment group. If a trial is showing increased death in the treatment group, then that's not a good trial. That means the drug is not good. Next. Same for secondary prevention trial. These trials are done on patients who already have heart attacks, strokes, diabetes, hypertension, vasculopathies. And the only two trials with some benefit is 4S and HPS. And as you can see, again, a lot of the trials are showing increased death in the treatment group. And if you go next and complete looking at all the studies, there's even more trials showing increased death in the treatment group. And these trials were ignored by the CTT, which is a research group that keeps churning out papers on statins, and they publish it in all the best journals. They have lots of money for that. But they pick and choose what trials had benefits, and they ignore the trials that didn't have any benefits. If you ask me, this is not scientific. This is not how research should be conducted. So I have a lot of concerns about the quality of this data to begin with. And I think this is something that many doctors have not really even looked into, I don't think.
The one thing that I have found interesting is here in the US, the cardiologists always say to me that there is not enough data to show that performing a heart cath is any more beneficial than the medications, the statins and the aspirin. And it doesn't even make sense logically. They say that people who have have narrowing in their heart, roto-rooted, cleared, stent placed, there's no evidence to show that they live any longer than someone who doesn't have anything done except for medications. I mean, logically, from an outsider, so you're smiling. So you agree, like from an outsider's perspective, where's the logic in that? And yet they've found and created evidence to show that the medications were the best course, for these patients. But my dad is living proof that if you get down and you resolve the metabolic syndrome that's plaguing him, and he got, he has 5 stents placed in his heart, LAD, right coronary, and his right coronary circumflex, that he's doing great. He's on his plant sterols, psyllium husk. He no longer is pre-diabetic. et cetera, et cetera, et cetera. Also, his MTHFR mutation has been resolved, by changing his dietary habits and increasing his supplementation. And he's doing great. He just had a PET scan, and that was in 2017 it started, 2026, and everything's clear in his heart.
Excellent. I mean, that's amazing. I have seen, I met a man at a conference actually who had metabolic syndrome. He had, I think, 9 different diseases. He was on 9 medications. He was having angina. He was having claudications, which is basically the symptom of kind of similar to peripheral artery disease. He was having plaques everywhere. He was having gout. He kind of went into, I think, low carb and fasting, and all of his symptoms resolved, and he is medication free.
Yeah.
So these things do work better than the drugs, because I'm showing you the evidence for the statin, and this is what I'm seeing by looking at the raw data from the studies.
And is
Plus-
this something that we can continue next Wednesday? Do you think you'll be available, or on another date that we can, continue? I think we've come to a good spot to stop. We've shown the data, gives everybody a chance to kind of go back, rewatch, and get some more questions together. And then we can further the discussion either next Wednesday or on an additional date. What do you think?
Yeah. I think we can do next Wednesday, where we can discuss in detail the side effects and why I'm personally not a fan, obviously, and then patients have to decide things for themselves. And then I can also go over some lifestyle strategies, some simple stuff that they can do to reverse metabolic syndrome.
Oh, would love that. Thank you so much, Dr. Hannah Mathew. Really appreciate it. Of course, make sure you email info@padhelp.org, info@padhelp.org. If you want to be in the live studio audience during our UK Hangout next week, where she is going to come back and we're going to talk about those wretched side effects that you all complain about every single day, but also some lifestyle modifications that you can make, things that you can do to improve your prognosis and be the best partner in your care. So thanks everyone for joining us. Make sure you like the video, subscribe to our channel, and we'll hopefully see you next week.